because you are definitely going to stay back for Dr. Harit's talk. I was worried that if I am the second one, you might leave. So I think not makes me feel a lot more secure.
Hello.
So I'm here second time. The first time was soon after I joined Apollo. I'm an alumni of All India Institute of Medical Sciences. I joined in 1979, and I took my voluntary retirement 2023 and joined Apollo. And I've stayed there ever since, which is not very common to stay at one place for very long. Let's hope that I stay there for a long time. The reason why we chose this talk about the advances in joint replacement is because joint replacement is now becoming a household term. There are over 5 lakh knee replacements done in India now, and there are at least 250,000 hip replacements done every year in India. So that's why it is of importance. See, when I was training, there was hardly any publications in joint replacement from India, because we started doing knee replacement when the Americans were publishing their 20 years results. So nothing that we did would make a news. But as the joint replacement picked up in India, many times we got implants which were not available to Americans because they were not FDA approved. So we started bouncing back. We worked on those implants, we worked on those techniques, and we started publishing. And now we do get a lot of international presentations. Last 5 years, not only I have made a presentation continuously on the latest in joint replacement in American Academy, but this year we won the best video award on hip replacement in the American Academy. There were a lot of entries from the America itself. So what I want to tell you is what has occurred in terms of advancement. Advancement has been on many fronts in joint replacement. There have been in the materials, in the designs, in the techniques, and in technologies. So let's talk quickly about my journey. I don't know how many of you have seen this joint. It is being popularized on internet quite a lot as a meniscal replacement procedure, MRP or resurfacing. It's just a type of knee replacement. So all those misguiding advertisements don't tell what it is. It is a type of knee replacement. It's only a partial knee replacement. So this I did on my teacher, who taught me but never did a single partial knee replacement. When he needed after retirement, he told me, can you do this on me? And I did that on both his knees. I've done it on big leaders. But this is a procedure which essentially is done when you have only 1/3 of the knee which is bad. And in the year 2008, we were funded by Government of India, Department of Science and Technology, for our collaboration with Oxford University on the work on this design, which is called the Oxford knee replacement, which is a partial knee replacement. And much the same, we heralded this procedure in India in 2008. And today, now more and more of technology. This is a navigated or computer assisted UKR, which I think we are the only center which did it shortly before it disappeared, because the only company which was providing this has packed its bags and gone from India because they couldn't put up with the system here, so to say. So this is actually computer assisted partial knee replacement, and we actually published our results of computer assisted partial knee replacement. But then from the conventional to computer assisted, we went on to robotic partial knee replacement. So it has got all the advantages of partial knee replacement, but it is done with the use of technology. So this is an example of the robotic total knee replacement, which is very routinely being done in India. So this is how it looks when you do it with robot. This is an example of a partial knee replacement done using a robot. And this is how we do the planning. We do a CT scan and we look at the sizes, and this is how it looks. And then the best part is the robotic hip replacement. The biggest problem with hip replacement is dislocation or nerve injury. So what we do is we do the best of the technique anywhere available anywhere in the world. We do it from the front, which is also called minimally invasive, which is also called direct anterior approach, in which you don't cut any muscles. You go from the front, go straight to the hip, and do it without cutting any muscles. So we did the first direct anterior in India. We did the first daycare hip replacement where a boy who was 23-year-old came to hospital, to the operation theatre directly from home, got operated, got into an auto at 4 o'clock in the evening and went home. And next day found himself on the front page of the Times of India, because this was the first time ever that a daycare hip replacement has been done in India. This was during COVID time. We didn't want to keep the patients in the ward. So that was the push for daycare hip replacement in India. And that was the first case. And we have now looked back. Now for young females who are conscious cosmetically, we do the hip replacement through a bikini incision, which is very, very inconspicuous. There was a young girl, 30-year-old, who was abandoned by her husband because of a hip disease. We did a bikini incision, told her, you go back and even your husband won't be able to find where the scar is. So this is just, these are small things, not a big thing. If you're going to have a joint replacement which is going to last you 25, 30 years, the scar may or may not matter. But for a young female, it makes a lot of difference. So we operated on young doctors, young computer engineers, and this has been great. And the second thing about hip replacement is limb length equalization, dislocation, which are the problems which lead to maximum litigation in the world, are taken care of by robotic hip replacement. So this is a lady who had a stiff hip and they are very prone to dislocation. We did a robotic hip replacement, and this was my presentation in San Diego last year on Orthodome, where I presented the video presentation of the kind of robotic hip replacement. You can imagine an Indian surgeon going and presenting in USA on a video selected for the robotic hip replacement in a complex primary hip replacement. That speaks a lot about the status which the joint replacement has gained in India. And now everybody has robots. There's actually a robot war out there. The surgeons don't fight, but the companies do. So this is how it has been. There was a traditional way of doing joint replacement. Then we had computer navigation. Then we made patient-specific guides. Then robotics. Now we have the artificial intelligence, and then we are getting more and more into virtual reality. Why do we need a robot? Because the human performance has limits. So we are able to do digital planning compared to visual estimation. We can do 3D planning. We can have haptic guided cuts. We can have a reproducible alignment and data assisted. I often tell the patient that if I want to put my femoral component in 2 degrees of tilt, there's no way a human body can do that, human eye can do that. But if I put it at 2 degrees, the robot will do that. So that is what robot has made us do, what it is nearly impossible for a human person to do. And that has led to a term called personalized joint replacement. Whether it is hip or a knee or a partial knee, we are doing a personalized knee replacement because no two people in this hall are alike. So we don't believe that putting all the knees and all the hips in one position is applicable to all. And that has led to personalized and joint replacement, and that's what it is. So other thing is that the orthopedic surgery needs a lot of precision, because if you're not precise, you can lead to premature failure, ligamental imbalance, dislocation, or early revision. And this is how the robotic joint replacements are increasing in number. See, there's a meteoric rise. Patients come and demand for the joint replacement, and these are the various systems which are available, and this is how the surgeries are on the rise. So this is a patient who had a deformity like this. So when we were doing conventional, we knew that this hip has gone up because of a deformity. And once we correct the deformity by hip replacement, the pelvis will come down. So how much to keep the length so that when the pelvis comes down, the legs are equal? The hip does not dislocate. It used to be only by experience. And now we have a robot which can make a 3D model of the implant and allow me to put the joint in a position so that it will still be ideal when the pelvis comes down and becomes straight. So this patient was very particular about his limb length, and I want to repeat that the maximum number of litigations in the world in the hip replacement are because the leg lengths were not equal. If you make somebody long more than 1 centimeter, he is very, very unhappy. You make him 2 centimeters long, he will come back and ask you to change the hip and put back it where it is equal. So these are the various studies which have shown that the robot helps you get equal length. In this particular case, we did the CT scan. What you see on the left side is as planned by the CT and the robot. This is the planning. And when we do it, we try to replicate that. So we put the cup in such a way that when the pelvis comes down, as it came down later, the legs were absolutely equal, and we had a very, very satisfied customer on our hands. Those are the advantages of technology, and this particular paper has said that this is actually a very good surgery, and it allows you to get very predictable results with minimized complications. About the knee replacement, again another example. We make a CT scan model of the knee, and we get all the planning. Then we look at the ligament laxity, and then we do the registration. Tell the robot where the knee is, where the femur is, where the tibia is. Then we do the dynamic balancing, and then we achieve perfect balance. This is how the perfect balance looks like. All the spaces are equal. So we adjust the position of the component so that we have absolutely balanced knee, half millimeter laxity on all sides. This is going to be a very, very happy patient. So this is called functional alignment, where you take a patient and you adjust the components, fine-tune their position so that the patient gets a very balanced knee without doing any soft tissue releases. How does that help? That allows faster recovery, less pain, and the patients are much more satisfied and much more happier. And these patients have been shown to have decreased pain, less opioid use, decreased stiffness, early function, early hospital discharge, decreased pain scores, and then decreased healthcare utilization, less hospital readiness. Another thing which I love about robots is the partial knee replacement. In a partial knee replacement, the component alignment is absolutely mandatory, because if you put them in a wrong position, they fail. And that way it has come as a boon. We put arrays to tell the robot where the femur and where the tibia are. We register, tell where the hip is, and then we use these registration, and then that is confirmed. The computer, the robot rectifies that whatever you are registered, it meets my impression of the joint, and then you see the laxity, see how the laxity in different position is, then you balance the knee perfectly. This is how the robot, this is before even I have touched the patient. This is just before I have cut anything. I have registered and showed the computer where it is. It shows me how the tracking will be, where the cartilage will be, and this shows that the tracking. On your right, it shows how well the femur component will track on the tibia, and this shows how well it will be placed on the cartilage. And then you go on to complete the procedure, and then you have a curve of soft tissue balance which is perfect. You see the blue is before surgery and the orange is after the components have been put in place, and this is how it looks. And you have again a very, very superior radiological accuracy, a much more satisfied patient. So the question is, when you have robot to do the hip replacement for you, the partial knee replacement for you, the total replacement for you, do you still need a human? Well, you know the answer to that one. The human advantage is the human heart, the human mind, and the human spirit. That can never be replicated by artificial intelligence or robot. So the robots run on algorithms, but the humans run on heart, man, and spirit. And I always say, robot is a great slave, but a terrible master. We can't allow the robot to become our master. It has to be our slave. It's the man behind the machine who matters. It's like a computer, garbage in, garbage out. You give him wrong registration, give it wrong information, it will very faithfully replicate, but you are the one who is going to be responsible for that. So the key takeaways from this short talk today are: the robotics enhance precision, consistency, and reproducibility. They begins with meticulous planning and accurate execution, and it's not just technology, it's technology put to the best use for a particular person to give him a personalized kind of joint replacement. We can personalize how we put the joint. So like I told you, earlier on, what we used to say to do was to put knee replacement in one particular position, perpendicular to the mechanical axis, and then do the all soft tissue releases to make it happen. Now we don't do any releases. We put the components as required in order to get a good balanced knee, as you saw, without doing any soft tissue releases, which reduces the post-operative pain, gives a more natural feeling to the patient, and gets a much more satisfied customer. So there are less outliers because using technology, but then although robots are powerful tools, but the surgical judgment, experience and compassion remain irreplaceable. So the future of orthopedics is not humans versus robots, it's humans empowered by robots. And the greatest innovation in the operation room is not robot, it's a surgeon who knows when to trust technology, when to challenge it, and when to rely on your own experience. And this is what drove this person to seek, our services and bless us with the chance to serve him. Thank you very much for your I'll be very happy to answer any questions.
Sir, in the end.
Oh, lovely. So that means anyway I still have to stay.
Yes. We'll make sure. We'll make sure.
That is only if you go close to the corner.
Thank you, Dr. Rajesh Malhotra. I know he is one of the best orthopedic surgeons in Delhi. And after a brilliant talk by him, there is another legend with us. The topic is very apt for him, the evolution of cancer treatment, knowledge sharing for better care. And who else is better than Dr. Harit Chaturvedi to talk about this topic? Dr. Harit is, I think, one of the, he did his MCH in surgical oncology in 1993. And one of the senior most surgical oncologists in Delhi. He has served in almost all the big hospitals of Delhi, including Apollo Hospital, where he is now at present also, and he earlier also served in Apollo for 4 years. He was Max Group Chairman of Oncology. He started his career from Batra Hospital, as far as I remember. Then he was in Rajiv Gandhi Cancer Hospital also. He has served in all the top hospitals of Delhi. And I now request Dr. Harit Chaturvedi to start his talk, a legend in surgical oncology. Dr. Harit.
Thank you very much, Dr. Thank you very much. So first of all, I want to really congratulate you. Not many events week after week continue for 1,000. It's a compliment to each one of you, but I do feel that Dr. Sushil is the person, the way he was monitoring today's meeting, and he made sure that people understand the meeting 2 बजे नहीं 1:30 बजे है. तो वो जो डंडा है ना, that is what makes things happen, and I really salute you because it is not possible to do such consistently these events. And that is why when Dr. Poddar said that the topic is for better care. These CMEs, these events are mainly for better care. So it is our partnership which will help us take this message forward to each patient, every corner, and make sure that we get the best in oncology or best in orthopedics and every space which we want to deliver. Because your interest, your focus is on patient care, and that is what we also want to achieve. So it's our job to convey to you and talk to you what is happening, and that is why I will say how 2026 is different from what I have seen. So as इसे पढ़ते चलता है क्या? ये वाला आ गया ना? हाँ ये सेलेक्ट नहीं है। वो यहाँ से नहीं So as Dr. Poddar said that I did my MCH in 1993. but I am in oncology since 1988. So मुझे भी अब 38 साल हो गए हैं oncology में, 38 years in oncology. So I've seen the whole spectrum, how things have changed. So I bring greetings from Inspirus Apollo Oncology team. We have a large team, and that is what I represent. And if I look at the current scenario, how things have changed. So I would say there are some very basic questions which one asks, why so many people work together? You need one oncologist to do magic. You don't need 20, 50 people. So in our department, we have 40 people in one department. Surgical, medical, radiation all put together. So actually, why that is important, that will come out in the end of this talk. Why there is need to sub-specialize. So Dr. Rajesh Malhotra knows that in orthopedic oncology, we have got 3 people today. Akshay Tiwari, Love Kapoor, and then Kamal is there with them, who is an associate. So in musculoskeletal tumors also, we have got 3 surgeons working as a team, backed by a medical oncologist and radiation oncologist, and also we are looking for radiologists and pathologists focused for musculoskeletal. And this thing goes from head to toe. So that is why we need large teams. That is why, and we realize a difference which subspecialization leads to. Because unless this happens, you cannot deliver modern care to our patients. Why should there be an MDT? What is the need to have every patient through the multidisciplinary team meeting? When all of us know guidelines. If Harit Chaturvedi does not know what is the treatment of breast cancer, he should not be treating breast cancer. I know guidelines. And likewise, my colleagues know guidelines. But whatever I know is always short of what is the best. And why we are short of that? Because the nuances of treatment come out on discussion. The fine tuning happens when discussion happens. And only when people of different specialties sit together and discuss a case, the nuances come out. That is why we focus on MDTs for all patients. It is happening, it is presently not happening to that level, but it will happen. Because that is something which we have built step by step in. Why should there be a clinical audit? चाहे हम जितना भी perfection करते रहें, in between mistakes happen, learnings happen. Unless there is a culture of discussion and audit, we are not able to change the game. So it is very important that the department holds these things with respect and dignity. This is very critical for the success. Why should we digitalize everything? So yesterday, Tuesday, we did a 6 hours workshop with IT team, health access team, clinical team and operations team to create a roadmap of clinical pathway and how we want to digitalize it. So these things are very crucial for long-term success of a growing department. And likewise, academic programs are so important because unless the young people and programs are there, things don't change. Invest in research and partnerships, very crucial. Today my colleague in head and neck, Dr. Ashat came and told me, sir, मेरे 4 trials चालू हो गए हैं. मैंने कहा very good, 4 महीने में अगर तुमने 4 trials चालू कर दिए, that's a good news. But the point is that spirit is very important, that things should happen. And last and not the least, rather probably the most important, why should every oncology service have a support group and advocacy program? Unless you keep hearing the patient's concerns, and these 2 things don't happen when the patient is admitted. These things happen when a special bond is created and you have a support group meeting, these things happen. That is why you need such a large team. That is why you need so many people to build a culture of sitting and talking and discussing each case and make it happen. So I'll just quickly wrap up in 4 decades. I'll broken it into 4 decades of oncology which I have seen. 88 to 98, what I saw was very limited availability of even things like CT scan. At Cancer Institute Chennai, CT was available only after director's permission. Otherwise, आप ultrasound से काम चला लो. एक मशीन थी, 1000 मरीज थे, possible ही नहीं था. And उसके पहले when I was in Kanpur, even ultrasound was a new entry in that era. 84 में पहली बार ultrasound आया था, I remember, and that was the, so things were at that level. The most common surgery in that era was KDB, खोलो, देखो, बंद करो. क्योंकि जब तक खोलते थे सब inoperable होता था. There was no concept of detailed imaging, understanding of tumor. There was no such concept. And we would end up doing biopsies and procedures. At that time, these were heroic surgeries. I'm not saying we were doing small surgeries. They were heroic surgery but the situation was bad. From 98 to 2000, there was rapid evolution in terms of understanding of tumor. And we saw true integration of multimodal treatment. CA esophagus, CA rectum, these things which are so complex. For the first time we realized that if we start with chemo radiation, then operate, results will improve significantly. And this jump we saw in these outcomes because of integration of other specialties. And that is where the concept of MDT became very strong. Because all these specialties were growing. So radiation also, medical also, radiology, pathology, things were happening at a very fast pace. And it was evolving. From 2008 to 2018 was the era when we saw a lot of new knowledge flowing in. When targets started emerging, the human genome complex, when that analysis happened, human genome atlas, that happened in early 2000, but the data started flowing in and the people started understanding tumor and other diseases, they realized that these mutations are of great value. But in our head, it was very clear, इस टेस्ट का कोई फायदा नहीं होगा. आप टेस्ट करा लो, 2% लोगों के लिए दवाइयाँ हैं, 98% की दवाई नहीं है, और टेस्ट की कॉस्ट थी 2 लाख, 2.5 लाख, 3 लाख. तो उतना खर्चा करने वाले कितने लोग थे, कितने लोगों की यूजिबिलिटी थी. So it was there, it was emerging, but it was not of great value. So target therapy had started taking shape, but it was not of great value. In this era of 18 to 28, we have seen a huge emergence of the understanding of target therapy, the understanding of immunotherapy, and the understanding of all these things in a very rapid way. And as Dr. Rajesh said, that the evolution of AI and robotic and technology is actually changing the game. Today in oncology department, we do about 35-40 robotic surgeries a month. Just to give an example. 35-40 robotic surgeries, we do about 250 surgeries a month. 10% के ऊपर, 15% के आसपास robotic surgery होती है. Because in every area it has made a change. Not just prostate cancer, not just rectal cancer, even in lung cancer, even in properly selected oral cancer, जो base of tongue tumors हैं यहाँ है, toss करना है, नेगेटिव करना है, lot of these things. Even in breast cancer it is coming up where we have to do, if you want to have you have a patient who is proven genetically positive, BRCA positive, and you're doing a prophylactic surgery. If you put a small incision in the axilla, do from there a nipple sparing, skin sparing mastectomy, you get the whole thing out from there, and then you do an implant and a reconstruction, there's no scar. Just as he talked about a bikini scar for a hip replacement, same theory is there here also. How to get the disease out without any minimal exposure or information to the public that what has gone through. So a lot has happened, but I must confess that next 5 years are very difficult to predict because इतनी तेजी से changes हो रहे हैं कि nobody knows what is coming in our way, but things are happening. So I'll just quickly take 2 cases, and then we see. So this is a young girl. She's a doctor herself, 29-year-old. She was preparing for her PG at that time, and she noticed a breast lump at a local center, which was assessed by an ultrasound something. They said fibroadenoma hai. She was also busy for exams, she left it, and in 3 months, that lump from 3 centimeters grew to 6 centimeters. It was a rapidly growing tumor in the upper outer quadrant, skin tethering, there was a node also positive, T3N1 disease. This is you're seeing on the mammogram, this lesion, young patient. We did an MRI also, this is the lesion. And so the next step is to do a biopsy. And we did a biopsy, which was an FNAC grade 3 triple negative breast cancer. As you would know, triple negative is the more aggressive type of breast cancer compared to a hormone positive or even HER2 positive breast cancer. It is more aggressive type, and FNAC of the axilla showed that the node is positive. So typically when I explain to people, I say there are 3 steps to cancer treatment. First is to understand the tumor properly. It is not just knowing the cancer, it's knowing the tumor type. So in breast cancer, it is enough to know ERP or HER2, but probably in the colon cancer today, even a localized colon cancer, we first do a MSI testing to see immune sensitive to nahi hai, then we make a plan. And likewise, in every area, there is a test or 2, which is essential. In fact, yesterday, a digital workshop in Batai, the pathologists were also there. So there was a question ki why there is a delay in pathology when we do a biopsies. Then the answer came because we need IC testing for all cases. Then the thing happened that when we knew need for IHC for all cases, then why don't we bill it up front? And because that leads to one more step and then more visit and all those things. Then happened that कुछ situations हैं जहाँ शायद जरूरत नहीं पड़ती है. And then we discussed actually कोई situation नहीं है जहाँ जरूरत नहीं पड़ती. Every patient we need something or the more information than a biopsy gives to make a decision. So that is so central. And then the next step is when you understand the tumor and you understand the stage of disease. For example, doing a FNAC for the axillary node. If I have not done an FNAC upfront for the axillary node and what the surgeon needs later, the surgeon doesn't know what the repetition. So it's important. And then we did a PET CT, it was non-metastatic. She was 29, unmarried. Before starting treatment, we must have a fertility consult. Because once the chemo started, the ovaries are knocked out, the opportunity for pregnancy is gone forever. So it is not acceptable in today's world. Therefore, that is crucial. The last point, not the least, is a genetic counseling. A young person going for treatment, a triple negative breast cancer. Triple negative, even if it's 75-year-old, the person must have a genetic counseling because the possibility of her BRCA positivity is more than 15%, 20%, even in 70-year-old. So the guidelines for all these things, किस age में, किस group में, ovary में किस में करना क्या करना. So it is important that this is done before starting treatment, and that was done. This was the PET CT finding, as you see here, and then we did a neoadjuvant chemotherapy. Before starting chemotherapy, a clip was placed, and this was the post-chemo excellent response to chemo. This is the marker clip. She had a breast conservation surgery after completion of chemo. It was possible in this patient. This is just a couple of surgical slides that the incision was planned in a manner that the scar comes along the inframammary crease. We don't want the scar on the upper outer quadrant. So हर जगह ये सोचना है how to minimalize. Today when so patients come and ask us कि आप कट कहाँ लगाओगे? तो हमें बताना होगा कट कहाँ लगाएंगे और हमें कहाँ हम छिपा सकते हैं कट को वो भी डिस्कस करते हैं. The point is that this is possible because of the evolution and understanding of tumor behavior and biology, and that was done. Oncoplasty was done from the inframammary crease. We raised a LICAP flap, rotated it, filled the cavity. So as you could see in the previous picture, nobody can make out in a post-op that this lady had a breast cancer surgery for upper outer quadrant tumor. And at 3 years follow-up, she is doing well and she's planning family. This is just, abhi baat karte karte yaad aa gayi. Yesterday I had a patient in my OPD. She is 42 now. She's also a doctor. She's practicing in Darbhanga, and she was operated 15 years back, and she has a child now. So she came very happy with the photo dikhai. Just to say that these things happen, and it's very rewarding for all of us. And then radiation was given, follow-up, and she's planning conception. So every step of treatment in cancer has evolved in a significant way. Whether you talk of prevention and screening, that has changed a lot. Talk of early breast cancer, 2/3 of patients today, we can actually avoid chemo by doing some advanced testing like Cmes, Oncotype, all that has made a difference. Locally advanced breast cancer, we never thought of doing a conservation surgery in locally advanced breast cancer. Today it is a gold standard, wherever possible. Even in metastatic breast cancer, things have changed. Not just in breast, everywhere, colon, rectal, lung, everywhere things have changed. But this is just the example which I have to give. Now, just a couple of points on modern systemic therapy, because today we can't talk of cancer treatment only in terms of this thing. The whole evolution in treatment has changed because the two big things have happened. The target therapy, where they have tracked the mutations. Dr. Nagar is there, he is practicing this every day, and the practice of immunotherapy, both in terms of adjuvant, neoadjuvant setting, various settings. So all of us need to know, and I'll quickly just go through it, I'll not take much of the time. The whole idea here is that identify the mutations, genetic mutations, the protein changes, and accordingly treat them. For example, the 70-year-old male presented with metastatic melanoma. Now what was the chance given to these patients earlier on? It was basically a poor opportunity, and advanced anal cancer melanoma with omentopetroneal disease, metastatic disease all over. And their performance status was 2. This is the report of the PET findings here. Omental disease, nodule above the diaphragm, and then palliative intent treatment shuru hua, poor response in unfit for dual blockade, had a nivolumab. And there what happens? That was progress. Then there was one more mutation picked up, BRAF mutation. And when this target therapy was started, anti-BRAF therapy, there was complete response in 2 months' time. After 2 months, there was complete response. The point is that if you get a good target, it creates magic. And that magic is something which is very rewarding for the patient. And this is not a success of a few weeks. It may be there for 3, 4, 5 years also. So if you have a good target, it works wonders. and that is what is important that every patient should get. Likewise, this is a triple negative breast cancer. Molecular profiling was PDL was very high, BRCA was negative. As I mentioned, all triple negative should have BRCA testing. All that was done. Liver, lung, bone mets. So what chance one would give to such a person? We will not give much chance. But having said that, ECOG-1 and palliative intent chemo was started, immuno was started, and this is the drug combination which was given. And this is the response. You see this disease here in the side, and now this is the post 3 cycles. Nearly complete metabolic response. The whole tumor has disappeared because the targets are working very well, and this happened. This is another patient again. Sorry. This is again a patient with hematuria. This is very interesting. This gentleman had a metastatic CA urinary bladder, and urinary bladder with not many chances. My colleague who was treating, Dr. Anshul Gupta, he told us there was stage 4 liver and bone mets. ECOG PS4, बिस्तर से उठ नहीं सकते थे. He was on bed, and incidentally, that very month, some publication came out which was supportive of uses of enfortumab for a particular mutation. And this gentleman could afford anything. He was a builder. He could afford anything. He said whatever is possible he want to do. And that testing was done. That came positive. So the publication had come in the month of February. Dr. Anshul had read that publication or came across it. In March, this gentleman presented. He did the test. It came positive. And see the result. This is a disease. Before starting treatment in the liver, started liver, lung deposits, extensive disease in the peritoneum, and this is the response in 3 months' time. Complete metabolic response. So all this is happening today. This is breast. This all 3 things: wonderful response, quick response to mutations, and this changing the game. And I must say that a lot of metastatic settings, even we are doing surgeries for these patients. So a lot is happening rapidly, and that is why it's important to work together. This is the last case I will discuss about the lung cancer. Again, stage 4 lung cancer, EGFR and positive, non-small brain mets and leptomeninges. This lady, 64-year-old, presented with a stage 4 lung cancer, pleural effusion, pericardial effusion, extensive disease on CT, upper lobe lesion, multiple lung nodules. The only thing which happened was that it was EGFR positive, and therefore you have an opportunity to treat her with osimertinib. Now that was osimertinib. This was started, complete metabolic response was sustained for 2 years. Now 2 साल तक वो metastatic setting, she responded very well. Subsequently, disease failed in the primary location. A small recurrence happened. So we decided to continue with osimertinib because she was responding well and treat this area with SBRT, radiation given to this area. However, it progressed in September 22, June 23 तक. 23, almost 8-9 months, and then she progressed again. Extensive disease. Again, biopsy was done. It was confirmed as adenocarcinoma. Then again, testing was done. Because it was growing rapidly, we thought of starting with chemo while waiting for the report to come. So she was started on chemo, and chemotherapy platinum doublet was started while waiting for CGP. And once that had happened, the report came. Again, EGFR mutation was there. She was started Jeftinib. Now something she had not responded for 2 cycles of chemo. The moment Jeftinib was started, within weeks there was a response. Rapid response Jeftinib within first generation TKI. ये tumor यहाँ से completely disappear होना शुरू हो गया within weeks of starting treatment. And that is what continued well for less 6 months. So February 23 to February 24, August 23 to February 24, she did very well. Then she got brain mets, leptomeningeal disease. Now at this time, when testing was done, liquid biopsy was done, there was emergence of HER2 positive, which was not there earlier. So anti-HER2 therapy started. And that also started with trastuzumab and TTXT based on HER2. And there was again a good response for a few months. However, disease revealed in leptomeninges. At that time, there was no mutation picked up on liquid biopsy. And then it occurred that why don't we do a CSF biopsy? Because outside the brain there was no disease, only in the leptomeningeal disease. On CSF again mutation was picked up. And so she was treated with intrathecal trastuzumab and osimertinib bi-weekly. That was started. And with that she responded well again and got under control. System is under control. And then MRI was conducted in July of 24. Again complete response, no disease at that time. Complete resolution. However, soon she had a intraparenchymal disease in the brain. That also progressed. And then we again did a biopsy, this time liquid biopsy and CSF liquid biopsy and also for the CSF testing. This time in the liquid biopsy mutation occurred and CSF was sterile because that was already treated. So you keep innovating and trying and do different things, and then again she responded well to treatment equivalent to. However, she passed away after 63 months and having a reasonably good quality of life throughout this journey. So this was possible because of continuously thinking, discussing and trying to solve things, and that is what is happening today. And based on this, I would say that whatever we have seen, we have come a long way in that on all fronts in healthcare. Every front we have seen so much of transformation, and I think it is very crucial that our partnership can take this to every patient in every corner. And thank you very much for doing this. Thank you.
लाइट जला दो.
Thank you, sir. Dr. Abhishek, please can you take your seat? We had two wonderful speakers, in fact, legends in their field of expertise, deliver two wonderful talks. It may look simple and very basic, but I think the message was great in both the talks. And I will first give it to my moderators, Dr. Abhishek first, to set the context for the first meeting.
Thanks, sir. Thanks once again, and it's always good to be back with family members. It's always like homecoming. And congratulations, sir. 999, and I don't know what it's called, like 10th century, 1000 next week. So I was supposed to kind of introduce Dr. Rajesh Malhotra, but I mean somehow I could not do that. No, actually, Dr. Rajesh Malhotra is one of those people whose name doesn't need any introduction. And now I see, when I see felicitations, citations and achievements, I think it was better I didn't start speaking, because that would have consumed the entire time of the CME. He has hundreds of awards, accolades, papers, and we all know that he has been the pillar. He is one of the pillars. Dr. Poddar mentioned that he is one of the best in Delhi. I think he is one of the best in India. And probably India is also not, I mean, he is one of the best in the world. And he chose a very contemporary topic, the role of robotics in modern orthopedics, especially joint replacement. So I would like the audience, people present, like esteemed people who are here, any questions, like Sir's presentation was very crisp, very delicate, and he highlighted like most of the benefits. So any queries, any questions which comes in the, sir.
Sir, I will take this opportunity to ask you some very basic questions. Sir, we know you that you are a wonderful operator on knee. Are you also doing other areas of the body?
Yes, we operate on all the joints. So joint replacement surgeon says I'm a joint replacement surgeon. But the only thing is that it's only the hip, knee and the shoulder which are successful. The ankle is still not successful, wrist is still not successful. Although ankle will possibly come before a good wrist comes. But then yes, we do. But the requirement for these is low. And see, the lower limb joint replacement is a necessity for the patient because they can't ambulate. But we see a lot of patients who need an upper limb surgery. Then because of apprehension, age or affordability, they refuse an upper limb replacement surgery even if it is required. Similarly, an elbow replacement, we would do just 1 in 2-3 years because that again does not allow a great function. You cannot lift more than say 5 pounds of weight with an replaced elbow. So I think the lower limbs have caught on because it leads to a lot more disability.
Right. Sir, you mentioned about the upper limbs being the area of neglect, not only for the patient at large, but also the, I would say, orthopedic surgeons. They are not so aggressive on a shoulder joint as they are on a knee joint.
So that's because it's a demand and supply.
Yes, sir, I understand that. So my question is different, sir. My question is, I have diabetes practice and I see a lot of periarthritis, severe periarthritis and frozen shoulders. What is an absolute indication for a arthroplasty on the shoulder for my patients? What should I be looking for? What is the red flag?
There is no indication for shoulder replacement in a periarthritis patient. The French philosopher Molière, when he talked about the frozen shoulder, he said, particularly with respect to frozen shoulder, all the diseases are self-limiting and the job of the physician is to keep the patient entertained till the disease becomes all right by itself. So the first thing I tell the frozen shoulder patient is that in 2 to 3 years it will become all right by itself and it will go and it will come back on the other shoulder, then it might come back on this very shoulder. So we'll treat you with physiotherapy, and if you have the patience and perseverance to go through this, then the physiotherapy will make it all right. If you have so much pain that you can't sleep at night, you think that you can't do physiotherapy because of pain, I'll give you a shoulder injection. And if you are in so much of pain that injection hasn't worked, we'll do a laser or the, not laser, the keyhole or the arthroscopic release, and you will be alright in 6 months instead of 2 years. But there's no place for shoulder replacement for periarthritis. And when I tell them this, none of the patients till now, except for one in last 3 years, has said you operate me for my frozen shoulder, and I don't mind that.
Right, sir.
Spine.
Sorry?
Spine you do?
Yeah, we have a team. See, spine needs a full-time thing. So I used to do spine with Dr. Dave because I was his favorite student. But the science has, the spine surgery has progressed a lot there. But you see, I was the head of the department in the premier teaching institution. So imagine my person who does mainly spine surgery is on vacation. And a patient comes and the head of the department should know whether this needs surgery or this should be treated conservatively. So you are not doing something every day with the nuances and the details of that, whether he needs the surgery or not, or what kind of surgery are not lost on a person who's heading the department.
So the first case that you showed was probably a unicompartmental this
Yes,
thing?
sir.
That was long ago.
Yes, sir.
Are you
2008.
Are you still doing unicompartmental?
My 40% practice is unicompartmental.
Or like
I've operated on politicians, bureaucrats, even my own teacher. Because I believe that a partial knee replacement is a very conservative surgery. There's less blood loss. My patients are actually ready to run on the day of surgery. And I'm sure, you see, we did the first daycare hip replacement in India. But till now, we have not been able to do daycare knee replacement in India. And the reason is it's such a painful surgery that after surgery, the pain doesn't allow. The patient goes home and comes back at midnight saying, "Doctor, I'm having pain." So the first time we saw a daycare knee replacement in France, they had a pump which costs more than the cost of the implant after it has been subsidized by Modi. So the implant is available for 50,000. The pump was 1.5 lakhs. So the company never introduced it. But the patients who go home the same day have a catheter in the knee with a pump which is continuously giving the analgesia in the knee. So there's nothing against sending. But the partial is much less painful. We do it through a 2-inch incision. We do not cut any muscle, like I said, in direct anterior hip, no muscle is cut. When I do a partial, no muscle is cut. And my patient, today I did this morning, and in the afternoon when I went for the round, the patient was eating and I said, "You have walked?" She said, "Yes, I walked to the washroom." I said, "Aapko discharge kar de." Because when the first daycare happens in India, it will be for partial. So those are the issues, because the partial circumvents many problems. In a 50-year-old, or in an 80-year-old, the partial is my first go-to, because in an 80-year-old it is 1/10 as risky as a total knee. In a 50-year-old, when they need a repeat surgery, it is much easier to revise a partial than to revise a total. But I operated on a retired Chief Secretary of Government of India at the age of 85, and we had no problem, did a partial. And he is just fine. I did a both side partial on leader of opposition in the parliament, and he is doing well after 12 years. So it's a great surgery, very conservative surgery, and it is actually the only surgery which gives you a near normal knee, because you don't cut any ligament.
Sir, alluding to the same question that you are just answering, many people come to us when we refer them for a total knee replacement, and they come back and they say that I have been advised partial knee replacement. The next question is that if we go in for a partial knee replacement, are we due for the full-fledged surgery down the line, maybe in a few years? So why spend twice?
So if a 70-year-old male has taken 70 years to wear out 1/3 of the knee, he'll take 140 years to wear out rest of the knee.
Okay.
That's what I tell them.
Okay.
But the fact is that there are certain technical details which we observe and which makes sure that a knee which has not damaged its outside for 50, 60, 70 years will remain like that. So I have done over 6,000 partial knees, and I have not revised a single one for the disease spreading to the outer compartment. It will spread to the outer compartment if you overcorrect. You see, you get a varus knee in osteoarthritis. If you do a partial and leave it in varus, all the load is on inner side, which is replaced. If I change it into a valgus, it will load the outer compartment, and that will become osteoarthritis. So a patient who gets osteoarthritis rapidly after partial is the one who has been wrongly done.
Right, sir. Sir, now my last question, sir. There is a lot of talk these days about stem cell and the PRPs, and a lot of people are, I would say, if we can call the term as bridge to total knee replacement. How are you placed on that front, and do you encourage your patients to go for stem cell and PRP if they are not willing for anything beyond a physiotherapy? What is your take on that?
So this is an excellent point. So a patient comes to me with an injection in a knee which is totally gone. And he says, "Doctor, I got this injection but I got no relief." So I said, "I'm sorry, now I can't touch you for next 6 months. Because if I operate on you after a steroid injection in the knee, there's a very high risk of infection." So the problem is, this is how it happens. I said, the doctor must have told you you need knee replacement, and you said, "I don't want." Then the doctor offered you arthroscopy, an injection, and you say, "Yes, this is fine, because this is not knee replacement." But the question is, you have to intervene at a time when you know that your intervention is worth it. In an osteoarthritis which is advanced, it is no more a biological problem of cartilage degeneration. It becomes a mechanical problem of malalignment. So if your knee is malaligned and the bone is on board, how will a platelet concentrate regenerate the knee in a knee which is bearing 90% of the load on the degenerated side? So unless you correct the alignment, nothing will work. About the platelet and stem cells, they are still experimental. They are not found place in any of the recommendations. They are just make a lot of money. I had a friend who was an American surgeon. He wrote in my books. I wrote 16 books, so I have a lot of friends all over the world. And he wrote a particular intervention came. It was later proven to be ineffective, but it sent 2 of my children to university. So that is how it works. But then, if the problem is mechanical, no injection, no PRP, no stem cell will work. And second thing is, the joint preservation should be done. And the most effective intervention for joint preservation is a realignment osteoarthritis. If I get a 40, 45, 50-year-old patient, I don't do joint replacement, but I say, if you are bone on bone, no cartilage, I cannot help you. But if it is not bone on bone, there is some cartilage left, I will not do a joint replacement on you. We do a high table osteotomy, correct the alignment, and in those patients, the joint preservation is very much important. So you have to look at every patient individually and see what the patient's requirement.
Sir, one knee at a time, both the knees at the same time.
So we published last year in Journal of Knee Surgery, and the title of the paper was both knees can be replaced simultaneously in selected patients. So if you don't select your patients carefully, you can cause harm to the patient, you can lose a patient, or the patient may go to ICU. So we have defined in that paper very specific criteria, and when a patient comes and tells me I want both done, if it's not suitable, I say please go and get it done by somebody else, because I can't violate and reach my own recommendation.
Right, sir. Sir, you are not on CGHS panel. How to approach you for our CGHS cases?
Now that is a difficult question. That I think you'll have to talk to Naresh, so he'll talk to his bosses.
Right, Dr. Tulsi and Dr. M.L. Kalra, sir. To Dr. Rajesh Malhotra.
To conclude.
So again a great talk, Dr. Rajesh. So what was interesting to note was that several guest lectures, citations in most of the reputed journals, and first day care, hip replacement surgery, you did. Let me talk you to about that young girl you talked about, hip replacement. Was it avascular necrosis, was it hip dysplasia, or was it juvenile idiopathic arthritis? You did talk about that.
So we have done all, sir. This one was avascular necrosis. Unfortunately, COVID has led to a lot of AVN. So there are two things I would like to say. One, Dr. Tulsi, I have known you all along. But if I had told you you are Dr. Tulsi, then you had said, tell me my neighbor's name, and then his neighbor's name, and then his neighbor's name. So I just gave up. Number one. Number two, before I came here, I was told there is only one person you need to be wary of. So sir, I have operated on dysplastic, juvenile inflammatory arthritis, avascular necrosis. Sir, I may tell you, we were the first center and the first surgeon in the world to do 4 joints replacement in a single sitting. And we have since done that on 8 patients. And it's not a claim made after a couple of years in a meeting, it's published. It's published, and because this was a man who was bedridden for 10 years with both hips and both knees involved, and because of my experience I know that if your both hips and both knees are involved, you replace 1, 2 or 3, the patient will not be able to walk, and many of them used to become stiff by the time you could do the rest of the joints. And also, we were the first center in the world to do both hip replacements at the same time in a single sitting. Patient is supine, one team is working from front here, one team is working from the front here. In 45 minutes, the patient is out of the theater with both knees replaced. Of course, that was at AIMS. I have not dared to do it at Apollo yet. But then, nothing scares us as long as the patient's safety is not compromised.
Okay, sir. My last and final question would be regarding robotics. Are all suited for robotics? Are there some contraindications here?
Sir, everybody would like to have a Mercedes he could have. So it is like that. So everybody is suitable for robotics. Everybody cannot afford robotics. And that will never happen, because by the time the technology becomes affordable, there will be more advanced technology which will be more expensive. So technology is not for everyone, but everyone is suitable for technology.
Let me differ here by saying not everybody is suitable for robotics, because if they are complex disorders, it's not that robotics would do justice to that. Apart from that, neuromuscular diseases and other, joint instabilities, etc., probably not suitable for robotics.
So let me differ with you here, sir. So, sir, what you are saying is an indication for joint replacement or
I'm
not?
talking about joint replacement.
No, sir, but what I am saying is any patient who needs joint replacement is suitable for joint replacement by robotics. My impression was whether you are asking every day, their risk of wound complications and risks of infection become less. So our first recommendation is to lose weight, but having said that, in USA, I have friends who have written in my book who operate on BMI of 65. But they are a different world. They are Caucasians and Americans who are in good health. I operated on a BMI of 42 yesterday. Because in India, if a patient comes back and says, I did Mounjaro, I did take Mounjaro, it didn't suit me, I vomited, I couldn't lose, now you have to do surgery on me. What do you do, sir? So that is what, but the first advice is not that you lose weight and I do surgery on you. Sir, my standard statement to patients is, you lose weight and you will not need me for several years.
Thank you, sir.
Sir, academic question have been asked by Dr. Chauhan and Dr. Tulsi. My question is more of a socio-economic status. Does bikini incision come with an extra cost?
No, sir.
No. So, had it come with extra cost, then I was thinking those who don't wear bikini ever, so like those who are wearing burqa and all that, they will not mind the extra that thing.
So who would not like to wear a bikini, sir? That's why I asked.
सर लाइक नहीं है कर नहीं पाते सोचे कौन सर मेरा एक साल से ये था बाकी तो मैं आई थिंक डॉक्टर हरीश
So, the next series of questions to Dr. Harit.
So I think everybody has joined, started dinner. I will ask some of our friends to listen to this session also. It was very interesting talk, and you should ask some questions to Dr. Harit also. From my side, only one question. In your first case, the fibroadenoma diagnosed on ultrasound, what is the message then? Was it a wrong diagnosis, or should she undergo FNAC at that time, or biopsy?
This is an excellent question, because I think for all diagnosis, everywhere, whether it's oral ulcer, whether it is a breast lump or mobile lump or anything, triple test is the mandate. Triple test means clinical, radiological, pathological correlation. On just seeing or examination, I should not dismiss any lesion, because all breast cancers, all oral cancers also start with a small ulcer or small lump, 5 millimeters, 7 millimeters, 9 millimeters. We start suspecting only when it is 5, 6, 7 centimeters. That is not the time. So everything requires triple test. Clinical evaluation, then imaging, or what I should say, endoscopy where it is possible, or some kind of evaluation and followed up with a biopsy. And these three things confirm the triple test.
So, I will just like to add to what Dr. Harit said. When I joined MBBS at All India Institute, we had lectures on medical ethics by eminent teachers. So Dr. Asim Prakash, who was the head of surgery, he gave a talk one day and he said, I had a young girl. I remember this is 1979, and he told us this story to the whole class of 79. He said there was a young lady who came with a lump and she said, I've been having it for 6 years. And I said, you're okay, it's okay if it has been there for 6 years. Nothing wrong with that. And subsequently, at a later day, she had a biopsy done and it was a malignancy. And, he said that she, went to the court and said that I was told that this is nothing. And I believed it. And following this is a story when one of the finance ministers of India, his PA brought his daughter to me. She had a swelling around the elbow. So I said, since when are you having this? She said, I'm having this for last 10 years. So I said, what do you want? Why do you want to remove it? He said, no, it's there. Why don't you just remove it? So we said that it's there for 10 years. It's okay. So we made a mistake of not doing an FNAC. We said we'll do a excisional biopsy because it was just 1 centimeter size on the anterior aspect of elbow. We excised it, it came out to be synovial sarcoma. Sitting there for 10 years, not increasing, not doing anything. Now came the problem. Now we said you get radiotherapy. Her father said she is 20 and she is a young girl, she has to get married. I don't want to get radiotherapy for her, and what will be the consequences, and will her elbow work or not. So what Dr. Harit said, I mean, don't believe anything. Don't believe your instinct, don't believe history, nothing. Just see it's a tumor. It's just like these days, unfortunately, they say every patient is a potential litigant, every swelling is a potential malignancy. I've had lesions in distal tibia, biopsy thrice in a young girl where we suspected Ewing. 3 biopsies came out to be non-conclusive, 4th biopsy came out to be Ewing, and that was the beginning of the trouble.
So just one note on that. So I have had likewise hundreds of stories. One thing I want to say that sometimes, as he said, don't believe your instinct. When I have a very innocuous looking lesion, something, everything is alright, I tell my patients, see, मुझे लग तो नहीं रहा है, but I will still recommend a biopsy because protocol says. And I have been proven 10 times wrong. लग नहीं रहा है, वो था निकल आया. 10 times wrong, more than 10 times.
Medically,
so as far as I am concerned, my prescription and my word will always be advice, imaging also, biopsy also. If there is a lump hai, I will always do an MRI. A lot of people may say it's overdoing. But my thing is, protocol has to be followed. You can't change the protocol because it is based on judgment of...
Medical legally also.
Everything.
My only last question, what is the role of FNAC in breast lumps? All the lumps should be, if at all, core biopsy should be done?
All should have a core biopsy.
No role of FNAC.
No role of FNAC, no role of excision biopsy, as Dr. Malhotra was saying. Incisional biopsies at some point, अभी का current data नहीं है, 15 साल 20 साल पुराना data है, that 30% of amputations globally happened because sarcomas had excision biopsies, poorly planned incisions. That led to 30% more amputations. So likewise, breast conservation नहीं हो पाता. A lot of things are not possible because poorly planned incisions.
So core biopsy should be done in all breast.
Not just breast.
Yes.
Anywhere, core biopsy. Sarcoma and core biopsy.
Dr. Chauhan.
Yeah.
Sir, GA breast is now not only a disease of middle-aged or elderly women, it is now populated to the younger population, and we are seeing increasingly great prevalence, increasing prevalence at an alarming rate in the younger population. I want to ask you, sir, is there any specific reason for that? And there is a reason for that. What is the reason?
So we all know about malignancies. So I will highlight few things and then I will come to you with this answer. One is cancer, cardiac, vascular diseases, strokes have very similar etiology. These are all lifestyle diseases. Is tobacco, alcohol is contributing on one side, increasing weight, sedentary lifestyle, poor dietary habits, all this leads to all this. And therefore you see a direct correlation. As economy goes up, the cancer incidence goes up. In US the cancer incidence is 3 times higher than what it is in India. Mara 125 per lakh per year and 350 per lakh per year. So the incidence goes slightly with that and is linked with the lifestyle and the way we are living lives. So it is known.
Sir, my second question is,
you may ask कि young people को तो उतना समय होता नहीं है उस lifestyle से. Actually it is not just that. The hormonal changes start very early and that results in that.
Right, sir. Sir, my second question is, when we were being taught surgery in Moderator, Professor Mediratta used to tell us when we were in 3rd year, always feel the breast lump with the flat of the head. Sir, should we not actually educate all of our patients, especially the younger girls who come to our clinics, their mothers and even their grandmothers, to percolate it through the generations, younger generations? I think that one single step can pick up a lot of breast tumors at a younger age. And why are we not having it as a national program, sir?
National program is genuinely करना है ना, focus on lifestyle in schools, not in adults, not in your clinics, because this DNA coding happens in school life. अभी मेरा आर्टिकल पब्लिश हुआ था हिंदू में on cancer prevention in India, how to combat the current. So my focus is only on how to bring this knowledge in school level. So my mission is life skills network build करना, जिससे कि आप स्कूल में लाइफ स्किल्स पे फोकस ला पाओ, क्योंकि हम कैंपेनिंग करते हैं, नॉलेज शेयरिंग करते हैं एडल्ट एज में, उसमें ज़्यादा फायदा होता नहीं। प्रिवेंशन करना है, स्कूल में आप डीएनए कोडिंग सही कर दो, हैबिट सही हो जाएंगी, बहुत सारी चीज़ें।
सर, आपने बहुत सारे अच्छे केसेस दिखाए and they were eye openers for us as per Dr. Malhotra's slides. Sir, immunotherapy has taken has actually gone in leaps and bounds in the last few years, and even in stage 4 cancers, immunotherapy has worked wonders.
Both target therapy plus immunotherapy.
It is also working wonders in CA breast.
Yes. Triple negative.
Triple negative.
PDL positive, triple negative. It has worked.
Right. Dr. Tulsi sir.
Dr. Chauhan, before you go there, just one word. See, I am a great fan of Rajesh Sharma. But today, the way we are being grilled by Dr. Chauhan, it gives me a feeling of Aapki Adalat.
Thank you, sir. Thank you.
So, Dr. Harit, wonderful case presentation.
Already डर लग रहा है डॉक्टर आपने जो माहौल सेट किया है ना, बोल लोग हैं। बहुत मैं निकल लेता हूँ, आप संभालो।
So, just two small questions. Why are cancers increasing worldwide, especially in younger people? Talking about breast, ovaries, pancreatic cancers, why are they increasing today? Is it
Lifestyle.
Yeah. So apart from lifestyle, it's also the aging process. People are living longer today.
आपने younger बोला, इसमें lifestyle ही चलेगा।
Yeah, younger is fine. That apart from that, why are cancers occurring more today? So, aging population, as we know, aging itself is a risk factor for cell divisions. So probably this is the factor. And not to forget obesity. We know at least a dozen cancers related to obesity. And for that, probably pancreatic cancers, gastric cancers, breast cancers, ovarian cancers.
Also, few cancers are coming down.
Tell us which cancers are coming down.
Cervical cancer.
Cervical?
Cervix.
That's because of the immunization.
No. Better hygienic conditions.
Better hygienic conditions is another.
Even before the vaccine.
Also preventive. Okay, sir. My final would be regarding, you remember my patient, Ritu Goel? CA breast stage 4. Distant metastasis to the lungs, to the liver, skeletal system, to the brain as well. Lived for 2.5 decades on targeted therapy, and finally she died of pneumonitis because of the targeted drugs, which is different to the pneumonia we know, which is an infective pneumonia. So pneumonitis, ILD because of the targeted drugs. Lived for 2.5 decades. Thank you, sir.
Again, no academic question, sir.
Thank you, sir.
No academic question, just a breather. I just want to know and take home message. I am extending the question of Dr. Chauhan. Self-breast examination for common adult female. Where do you place this importance? Do you propagate or do you want to?
So frankly, self-breast examination has value but limited value. Bigger, more important is being breast aware. What we use the word being breast aware, being comfortable with your breast and breast aware. Because any of these rituals, they don't stay for long. But if you are aware, then it helps in picking up early cancer. But I must give you one more data point. 25 years, 30 years back, there is a publication that the average breast tumor size in India was about 4.5 centimeters. And today the average size comes down to 2 centimeters. And the reason for that is that overall, the awareness has gone up.
So, do you recommend that at least educated people, they should be, awareness will bring
Yes.
Yes. Thank you.
So one small question. Sir, when you say that targeted therapy and immunotherapy works on the patient, and there's a reversal and there's an improvement in the patient, I want to know what do the scans actually show? The area which has already been destroyed, Doesn't it show on the CT scan later also? Are you seeing the progressiveness is stopped?
It heals. It heals. It becomes normal. For example, a bone which is weakened, electric lesion है वो fill up हो जाएगी.
So you are saying the lesion which is cancerous in nature will heal up?
हाँ, correct. वो cancer cells मर जाते हैं, replaced by normal tissue.
Sir, मेरा last question, Dr. Harit. Sir, we have been laying too much emphasis on the right, on the outer quadrant. When should we start suspecting malignancy in the other quadrants? Any red flags, sir?
नहीं, हर जगह एक ही है. The thing is that upper outer quadrant has maximum breast tissue. The incidence is same. Okay. The volume of tissue is much more in the upper.
Even if
upper Indian has least tissue, lower outer Indian has similar tissue. So this is the reason why you find 35% of breast cancer at outer quadrant.
So even if we have a tumor which is in the inner quadrant, we should be equally aware.
Triple test is applies for everything anywhere in the body. No exceptions.
Thank you, sir. We had two wonderful talks. I would now just ask for the carry home message from Dr. Abhishek Mishra for Dr. Rajesh Malhotra's talk and Dr. S K Poddar sir for Dr. Harit Chaturvedi's talk. Your carry home message from just maybe in a line or two.
Two lines, sir. First line, the answer to one of the questions you asked, like, is there a guarantee that you don't undergo total knee replacement after you undergone a partial knee replacement? So I would like to add what, apart from what sir has said, that there is a company called Zimmer Garments which makes a knee called Oxford.